All right, let's talk about a class of infections that honestly are often missed but can be incredibly lethal: fungal infections. As our patients get more complex, more immunocompromised, being able to spot these pathogens isn't just a nice skill to have anymore. It's absolutely essential for any clinician.
So I want to start with just one number, 40%. Think about all the common infections people get in the hospital. What do you think this number represents? Just take a second, because the answer really shows why we need to be paying attention.
Yeah, that's the mortality rate for systemic candidiasis. And get this, it's the fourth most common bloodstream infection in our hospitals. A 40% mortality rate, that's almost a coin flip. It's a sobering statistic that tells you just how high the stakes are when we're dealing with this.
So let's kick things off with the most common offender, Candida. Now, the single most important thing to get right with Candida is figuring out the difference between simple colonization, where it's just living on a surface without causing problems, and a true deadly infection. Nailing that distinction is a huge part of the job.
Think of this slide as your mental checklist. Does your patient have a central line? That's basically a superhighway for fungus right into the bloodstream. Are they on big gun antibiotics that have wiped out all the good bacteria? Or on TPN, which is like a nonstop sugar buffet for yeast? Been in the ICU for more than a few days? Any one of these should set off alarm bells for candidemia.
Okay, and this right here is the critical decision point. You find some yeast in a sputum sample or in the urine of a patient with a catheter, it's probably just colonization. But listen, if there is one thing you take away today, it's this. Candida in a blood culture is never a contaminant. I'll say it again. It is never a contaminant. It always means there's a real infection and you have to treat it fast.
But here's the kicker, and this is what makes diagnosis such a headache. Up to 60% of patients who actually have invasive candidiasis will have negative blood cultures. Negative. So if you're just waiting on a blood culture to turn positive, you could be dangerously behind. Thankfully, we have some newer tools like the T2 magnetic resonance assay, which can find Candida DNA in the blood, or the beta-D-glucan assay. These can give us a heads up much, much faster.
Okay, so you've got a positive culture, or your suspicion is sky high. What's the game plan? It's these 4 steps. 1. Start an echinocandin, like caspofungin, right away. 2. Pull out any central lines or catheters if you possibly can. 3. Keep drawing blood cultures until they're negative, so you know the infection is gone. And 4. Get an eye exam to make sure the fungus hasn't spread to the back of the eye.
All right, let's switch gears to our next major pathogen, Aspergillus. If you think of Candida as coming from inside the body, think of Aspergillus as an airborne threat. We breathe in the spores, and for someone who's severely immunocompromised, it sets up shop in the lungs.
So if you're worried about invasive aspergillosis, the chest CT is your best friend. And this is the classic sign you're looking for, especially early on. It's called the halo sign. You see that solid white nodule in the middle? That fuzzy, hazy area around it, that's actually blood. It's a sign that the fungus is already invading blood vessels, and that's bad news.
And this is what's actually causing that halo sign on the CT. When you look at the tissue under a microscope, you see this. These are the fungal hyphae, branching at those distinctive, sharp, 45-degree angles. This is the fungus, literally tunneling through the lung tissue and into the blood vessels.
So who gets this awful infection? Well, the list of risk factors is basically a roll call of the most immunocompromised patients in the hospital. People with almost no white blood cells, those who've had a stem cell or solid organ transplant, these are the classic hosts. In these patients, your suspicion for Aspergillus needs to be on a hair trigger.
Look, this infection can move shockingly fast. You can't afford to wait around. The first-line treatment is voriconazole, and in most cases, waiting for a definitive biopsy is a luxury you just don't have. You have to start treatment based on high suspicion from the clinical picture and the CT scan.
Okay, buckle up. We're going to do a quick lightning round, a quick tour of a few other fungi that you definitely need to have on your radar. For these guys, sometimes just one little piece of the patient's history is the key that unlocks the whole case. First up, Cryptococcus. When you hear crypto, I want you to immediately think fungal meningitis, especially in patients with advanced HIV or organ transplant recipients. And here's the absolute, can't miss, must-do step. When you do the lumbar puncture, you have to check the opening pressure. It's often dangerously high, and managing that pressure is just as important as the antifungal meds. Next, we have the endemic fungi. And for these, geography is everything. The travel history is your most important diagnostic tool. Patients been to the Ohio or Mississippi River valleys? You gotta think histo or blasto. Were they out in the Southwest, like Arizona or California? Coccidioides or valley fever should be at the very top of your list. And a quick pearl for blasto. It's known as a great mimicker, and it can show up as a lung nodule that looks just like lung cancer.
Okay, now we have to talk about what is, without a doubt, one of the most terrifying, most rapidly destructive fungal infections that exists. This is mucormycosis. And I want you to think of this not just as an infection, but as a full-blown surgical emergency.
And this is what it can do. This image shows the classic, devastating form that starts in the sinuses and then just rips through the surrounding tissue, into the eye socket, and even into the brain. Your classic patient for this is someone with diabetes, especially if they're in DKA. That black area you see, that's not a scab. That's dead tissue. It's called an Escher, and it is the hallmark of this disease.
With mucor, every single minute counts. It invades blood vessels, causes clots, and cuts off the blood supply. That's why the tissue literally dies and turns black. So if you even suspect it, you have to act. The treatment is a two-pronged attack. A surgeon needs to go in and aggressively cut out all of that dead tissue. And at the same time, you start them on high-dose liposomal amphotericin B. And even when we do everything right, the mortality rate is still incredibly high.
All right, yeah, I know that was a lot to cover, from the everyday to the truly terrifying. So let's bring it all home and boil it down to the key pearls you can actually use on your next shift.
So here's the bottom line. First, always keep a high index of suspicion in at-risk patients. Don't let a negative blood culture make you feel too comfortable. Lean on those newer non-culture tests to get a faster diagnosis. And maybe most importantly, understand that starting treatment early, even if you're not 100% sure, is what saves lives. If you see black dead tissue, your first thought is mucor, and your first call should be to a surgeon.
So I'll leave you with this one question, the one thing to keep in the back of your mind. When you have that patient with a fever that just won't go away, and you've thrown all the usual antibiotics at them and nothing's working, are you thinking fungus? Because asking that simple question, that could be the thing that saves a life. Thanks for joining me for this explainer.